Hello everyone, in this module we will be learning about renal dysgenesis and various cystic diseases of the kidney. Unfortunately, this particular module has a lot of factual information in it. That is because most of these conditions that we are going to discuss are some sort of congenital disorders. Okay, so there's not much of pathophysiology involved. So there is not much of a disease process involved. So there are few points or few salient points that you need to know regarding each of these diseases. If you remember those particular keywords, then that will make your life that much easier. It will help you answer those particular MCQs in a much more easier fashion. Just one particular saying with regards to polycystic kidney disease: the organ will enlarge, but the function will diminish. Okay, so this is like a stark reminder to all of you that size does not equal strength. Okay, so having said that, let's directly dive into this particular module. First, let's talk about renal dysgenesis. Okay, now before that, we have covered this whenever we spoke about the congenital anomalies of the kidney. Please note that there is a difference between agenesis and dysgenesis. Agenesis means the kidney has not formed at all. Dysgenesis means the formation has started and then something has happened and it is stopped. That means some lack of communication is there. That means probably the kidney is formed but it's not communicating to the bladder, or there is some hypoplasia, a part of the kidney is not well developed. All this comes under renal dysgenesis. If the kidney doesn't form at all because of certain abnormalities in the embryology, then we end up having renal agenesis. In agenesis, we have already discussed unilateral agenesis and bilateral renal agenesis. When it comes to dysgenesis, we will be learning about renal dysplasia, hypoplasia, Oligomeganephronia, hypodysplasia, and a condition called as the Ask-upmark kidney. So once we cover all of this, then we will jump into the cystic diseases of the kidney. Now, before we go there, a quick recap about the embryology of the urinary system. So we initially have the pronephros, which kind of forms and then vanishes by itself. Then from where it leaves or from where it vanishes, then the next segment develops, that is called as the mesonephros. Okay, and from this mesonephros, you're going to get a small ureteric bud which communicates with the metanephric mesenchyme. Okay, this is basically your metanephros. So this becomes your future kidney, and the ureteric bud becomes your future ureter. Okay, so this is the basics of understanding the embryology of how the urinary system develops. Now, like I was saying, the ureteric bud will come and it will communicate with the metanephric mesenchyme. And please note, both of these are codependent. That means the ureteric bud will stimulate condensation of the metanephric mesenchyme. At the same time, the metanephric mesenchyme will stimulate the ureteric bud to grow into it and branch out. Okay, so they are codependent on each other. So if there is a lack of coordination between the two, that is what gives rise to the various problems. And please note, there are a lot of enzymes and hormones that are involved in this codependency of the ureteric bud and the metanephric mesenchyme. So this becomes your future kidney, this becomes your ureter, and the ureteric bud, which spreads inside the metanephric mesenchyme, eventually goes on to form the collecting system. Alright, so that is what forms the minor calyces, the major calyces, and the renal pelvis. So let's understand about renal dysplasia. This is the first condition we're going to talk about. So here, like I said, there is a ureteric bud and the metanephric mesenchyme, and they're supposed to communicate with each other. So if there is some issue with the communication, okay, some loss of communication, then there is an arrest of growth. So when there is an arrest of growth, that means it doesn't mature. So what do you mean by that? You will find immature cells in these particular patients. It's as simple as that. Okay. Now the histological diagnosis of renal dysplasia is embryonic and immature mesenchyme and presence of primitive renal components. And you have to know that this is the most common, okay? That is one of the primary cause for end-stage renal disease. Why? That is because all the cells that are there are immature. If they're immature, that means they don't do the function of filtration of the urine that very well. So eventually the patient will end up with end-stage renal disease. Now, if you look at the histology per se, there will be altered renal architecture. Okay, this is important. Premature glomeruli, and then you will have premature nephron cells. Okay, premature nephron cells. So if you remember our module on development of the urinary system, we told you first initially you're going to have a comma-shaped body. As that elongates, it becomes an S-shaped body, and then this becomes the future PCT, DCT, and the loop of Henle. Correct? Now, because there is an arrest, they kind of get stuck at this comma and S-shaped levels. Okay, so you will find your premature nephron cells. These are called as a S-shaped body and the comma-shaped body. There will be presence of primitive ducts. So what are these primitive ducts? They're nothing but cartilage and tubules that are surrounded by the fibromuscular tissue. And this point is very, very, very important. Okay, very, very important because this has been asked. Okay. Where do you find the primitive ducts? You will find it in renal dysplasia. Now, if you look at the etiology, there are two particular theories. One is the genetic or the ureteric bud theory. Second is the obstructive theory. So, with discussing, you will have a ureteric bud and you're going to have a metanephric mesenchyme. Normally, this is supposed to go right into the center of the metanephric mesenchyme. So, by chance, if there is an abnormal ureteric bud development which communicates with the periphery, okay? So, this is the ureteric bud, but if it communicates with the periphery of the kidney like this, okay? It communicates with the periphery of the kidney. This is what leads to renal dysplasia. Next is your obstructive theory, where there is an embryonic obstruction to growth, okay? Embryonic obstruction. So, what will happen? You will have renal dysplasia in the peripheral region and you will have subcapsular cysts. Now, the cause for these subcapsular cysts are still not well established, okay? But you need to know that they will have peripheral region dysplastic lesions. Now, this renal dysplasia can be associated with certain genetic syndromes such as the Fraser syndrome, the Bohr syndrome, the renal coloboma syndrome, Kallman syndrome, Simpson-Golabi-Bammel syndrome, Smith-Lemli-Opitz syndrome, hypoparathyroidism, sensory neural deafness, renal dysplasia syndrome, Town-Brox syndrome. Okay, basically you don't have to mug it up, just know that it is associated with a lot of syndromes. Okay, one particular thing that you guys need to know is the familial renal adysplasia. So here what will happen, it is a combination of renal agenesis and renal dysgenesis in the family. Okay, that means in a particular lineage, some patients will have renal agenesis, some patients will have some sort of dysgenesis or dysplasia or hypoplasia going on. So this particular thing is called as a familial renal adysplasia. Alright. Now, how do you evaluate these patients? You will perform an ultrasound of the abdomen and you will note that the kidneys are hyperechoic. Okay, they are hyperechoic, and because the growth is arrested and it is stunted, automatically it means that the kidney size will be small. Okay, you will have a small kidney. Now, sometimes they might ask you, whenever you are saying hyperechoic, it must be in relation to something else. Okay, you must have an isoechoic and then you will have a hyperechoic. So, what are you comparing the echogenicity of the kidney to? You are comparing this to that of the liver. Okay, so it is hyperechoic when compared to the liver. That is what it means. All right. So the kidney is hyperechoic when compared to the liver. Apart from that, there will be loss of corticomedullary differentiation. You will find a lot of cysts, and like I've already told you, there is no obvious explanation as to why the cysts are formed. There will be loss of differentiation between the parenchyma and the fat. What fat am I talking? I am talking about the perirenal fat. Normally, when you do an ultrasound, you should be able to differentiate the parenchyma of the kidney and you should be able to identify what is the perirenal fat. In this particular condition, because everything is still in the primitive stages, it becomes very difficult to differentiate between the two of them. Okay, so there's a loss of differentiation between the parenchyma and the fat. So that was about renal dysplasia. Now we go on to renal hypoplasia. So in hypoplasia, as the name suggests, hypo, that means everything is less. Plasia is growth. So that means the growth is less. So the growth is less, the numbers are less, the size is less. So you're going to get a very, very small kidney. Okay. So what happens in these patients is that you will have underdevelopment of a tissue or organ, either in terms of number of cells or in terms of reduction in size. Okay. Either or you will have both. Either there is a reduced number of cells or there is a reduction in size, or sometimes there will be a reduction in number and a reduction in size, and that is what we call as a renal hypoplasia. Now, this is usually associated with ectopic ureteric orifices, and whenever you do a scan, like I told you, because everything is hypoplastic, the size will be very, very small, it's reduced. You will have dilated calyces. And because the kidney is small, of course, the functioning also will take a hit. So the renal function is first initially assessed biochemically. That means do your basic blood test, the blood urea nitrogen and the serum creatinine. And if there is unilateral hypoplasia, you can try and identify it using a radionuclide studies such as the DTPA and the MAG3 scans. So in that way, you will get to know which part of the kidney is not functioning, or if the kidney is completely non-functional or not. That is the information what you're going to get with the help of radionuclide studies. Now this hypoplasia can either be unilateral or bilateral. Whenever one kidney is shrunk, the opposite kidney tends to take the brunt of it. That means this tends to overwork to compensate for the loss of functioning in one kidney. So here there will be compensatory hypertrophy of the opposite kidney in a case of unilateral renal hypoplasia. Remember, this is also the same case in a unilateral renal agenesis as well. There also you will have a compensatory hypertrophy of the opposite kidney or the contralateral kidney. Next, we're going to talk about a condition called as the Oligomeganephronia. As the name suggests, oligo means less in number. Meganephronia, that means size is increased. Okay, nephron is there, size is increased. Size is increased. So number is less, but size is more. That is what is oligomeganephronia. So just remember that much. So it is a type of renal hypoplasia. Here also what happens, the growth is arrested usually at 14 to 20 weeks of intrauterine life. Okay. And here what happens, there is a quantitative defect of the renal parenchyma. Now here I told you the number is less, whereas size of nephron is more. Okay. Now this size can sometimes be as much as 4 times that of a normal nephron. 4 times of a normal nephron. Now if I give a question to you at this point of time, what is going to happen to the size of the kidney? I agree the number is less, but at the same time the nephrons are larger. So theoretically, the first thing that is going to come to our mind is that if one is less and the other one is compensating, it should be a normal sized kidney. No, that is because the reduction in number is far greater when compared to the increase in size. Let us take an example. Let's assume there are 100 nephrons, okay, in a normal kidney. Whereas in oligomeganephronia, there will only be 10 nephrons, okay. So there is a 10-fold reduction in the number of nephrons. Probably the size might go up to 4 times. So it might kind of come up to, let us say, somewhere the size of a kidney which has 40 nephrons. But what is the size of a normal kidney? It is that of 100 nephrons, okay. So overall, even though the size of the nephrons are more, the size of the overall kidney will still be less. Keep that in mind. Okay. So less in number is more significant when compared to the increase in size of the individual nephrons. Now these patients will have a male predominant pattern, and most of the times you tend to diagnose this after first year of age. Okay, that is when the diagnosis comes to light. And these patients will have a short stature. They will present to you with polyuria, polydipsia and proteinuria. And please keep it in mind, it is a progressive disorder. That means eventually these patients will also end up with some sort of end-stage renal disease. Now here, there is an issue with the PAX2 homeobox transcription factor, and any abnormality in this is what is going to lead to that arrest in the development of the particular kidney. Now, how are you going to evaluate these patients? I already told you they will have proteinuria. Okay, so proteinuria is the first laboratory manifestation. Why? Because the kidneys are not functioning well, so they're unable to absorb the proteins. The proteins are going to get thrown out into the urine. Okay, and as age progresses, I've told you it's a progressive disease, so there will be a gradual decline in the renal function. The blood urea nitrogen will go up, the creatinine levels will go up. These patients can have hyponatremia and metabolic acidosis. All these are your biochemical tests. Okay, biochemical tests. And when you perform a USG, I have told you they will have small sized kidneys. Okay, even though the individual size of the nephron is more, overall size of the kidney is still small. Very, very important point. Keep this in mind. Now, there is no obvious treatment for this particular condition. It's more or less trying to support the various shortcomings that have occurred in the patient in terms of the development. So, more or less it's supportive treatment, high fluid intake and correction of the salt losses and acidosis. I told you these patients will have hyponatremia and metabolic acidosis, so try and correct that. Daily dietary protein should be limited to 1.5 gram per kg per day during the stable phase. That is because they are having proteinuria. Okay, and then when you talk about treatment, ACE inhibitors may be of some benefit to try and slow the progression of the renal failure. So you can't cure them, but you can prevent further deterioration, and this is with the help of ACE inhibitors. Now the allograft which comes from a living related donor is acceptable. That is because the disease is not familial. Okay, it is not a familial disease. So therefore you can accept an allograft from a related donor. Next we are going to talk about a condition called as the Ask-upmark kidney. This is called as a segmental hypoplasia. So here what happens, like I've told you, it is a segmental renal hypoplasia. The mean age of presentation. The mean age of presentation is 10 years. Okay, that's the mean age of presentation. Now, the most frequent symptom or finding that they come to you with is hypertension. Okay, so most of these patients will have an elevated blood pressure reading, and they will have extremely acquired reflux nephropathy. That means these patients will have a vesicoureteric reflux. So whenever there is a vesicoureteric reflux, the urine from the bladder is coming up into the ureter and then go into the kidney. Now, if it's only urine, it's okay. But sometimes a bacteria can get through to it. So this can lead to pyelonephritis. And attacks of pyelonephritis will have their own complications. And one such complication is scarring of the kidney. Okay. So what is going to happen? Because of this reflux nephropathy, there is a scarring of the kidney. And that is what is called as a segmental hypoplasia, because that area of the scar will become hypoplastic because of repeated fibrosis and repeated infection that's happening there. That is the pathophysiology of the Ask-upmark kidney. So etiology, like I said, reflux. Apart from that, you can have segmental vascular anomalies. So in short, this is the kidney, the ureter, and they're going to empty into the bladder. So a repeated reflux will cause pyelonephritis. So there will be scarring in this particular area. So remember, you will have a wedge-shaped scar, okay, in the center of the kidney, wherever the ureter enters, a wedge-shaped scar. So there are two explanations. One is the reflux. Second is, this is where the blood vessels enter, right? So if there are some vascular anomalies here, even that can lead to some sort of scarring and fibrosis in this area. So that is the other etiology, that is a segmental vascular anomaly. Now looking at the clinical features, these patients will have severe hypertension. They will present you with headaches, encephalopathy, retinopathy, and proteinuria if the condition is bilateral. Okay. So if both the kidneys are involved, these patients will come to you with proteinuria. So how do you evaluate these patients? Most of the times it is a unilateral disease. Okay. Now when you look at the kidney with the help of some sort of renal imaging, you will find a small kidney with a deep, narrow segmental scar or a slit-like scar found in the mid-zone. This is what we were discussing, right? So if there is scarring in this particular area because of the reflux, this is a deep and it is narrow. You see, it's not wide. It's not like the scarring is in all this area. It is a deep, narrow, a wedge shape or a slit-like scar. And that is what we call as the Ask-upmark kidney. Apart from that, they can have arteriosclerosis and juxtaglomerular hyperplasia. So both of these are also found in the case of Ask-upmark kidney. So how do you manage these patients? It is more or less supportive. Like I told you, you can't reverse scarring. Scarring is happened means it's happened. Kidney can't regenerate. Okay. So now your idea is to try and treat the complications. What are the complications that we are dealing with? These patients will have hypertension. So if this is a unilateral disease and there is severe hypertension which is not getting controlled by medicine, consider doing a nephrectomy. Like remove the involved disease kidney, okay? Then the BP will come under control. That is the idea. So if it is a unilateral disease, consider a nephrectomy. This will help reduce the hypertension. Now, if it is a bilaterally involved disease, that means if both the kidneys are involved, now nephrectomy goes out of the picture. Okay. Now it's more or less, eventually it's understood that patient will have some sort of end-stage renal disease. Okay. So manage them conservatively for as long as you can. And once the kidneys have completely stopped functioning, these patients will need dialysis and transplantation. Okay. Dialysis and transplantation. And correction of reflux, okay, that is the main etiology, right? So if you correct the vesico-ureteric reflux, it may prevent further renal damage. So it doesn't reverse the scarring. That is what you have to understand. Once the damage is done, it is done. And the scarring will continue to have the hypertension. So by correcting the VUR, the hypertension will not get better. That is what you need to understand. You can prevent further pyelonephritis, further UTI by correcting the reflux. But you can't correct the scarring, you can't correct the hypertension, that will persist. Even though you correct the reflux, the hypertension and the scarring will persist. Keep that in mind. Last condition we are going to discuss in this renal dysgenesis topic is the renal hypodysplasia. Now, hypodysplasia means it has both features of hypoplasia where there is a shrunken growth and dysplasia where there is an arrested sort of growth. So hypodysplasia may be associated with a wide spectrum of urological diseases such as your primary obstructive megaureter, the uretrocele, urethral obstruction, or the prune belly syndrome. So this was few lines about renal hypodysplasia. Next we move on to a slightly larger topic, that is the cystic diseases of the kidney. Okay. In cystic disease of kidney, few one-liners that you need to know is kidney is the most common organ to have cystic diseases. Okay, which indirectly means that you can find cystic problems throughout the body in various other organs such as the liver, the pancreas, the spleen, so on and so forth. But amongst all the organs in the body, kidney is the one which is most commonly susceptible to this cystic diseases. Most of these cysts are associated with the tubules, not the parenchyma. Okay, it's not the cortex or the medulla. It is the collecting system or the tubules. Okay, This is where most of the cysts arise from. That is what you need to keep in mind. Okay? Most of the cysts arise from the tubules and not parenchyma. Now these tubules are lined by dedifferentiated cells. Okay? They are lined by dedifferentiated cells, which means that once a small part of the tubule gets isolated, they have dedifferentiated cells which keep on secreting. So fluid, once it keeps on getting accumulated within this area, it will form a cyst. It's as simple as that. Okay? And that is what leads to the cystic diseases of the kidney. Coming to the pathophysiology, there is proliferation of the epithelial cells in the segments of the renal tubule. There is accumulation of fluid within the expanding tubule segment. Okay, like I told, the segment of the renal tubule which kind of gets separated, there will be proliferation of the epithelial cells. The epithelial cells will secrete fluid, so that will cause an expanding tubular segment, and they will have disturbed organization and metabolism of the extracellular matrix. Again, don't break your head too much. Like I said, a part of it gets separated. They're lined by epithelium. Job of epithelium is to secrete. Okay, that is why they're called a secretory epithelium, correct? So it will secrete. There will be collection of fluid because it can't communicate elsewhere. That is what leads to cysts. Now, the idea in this particular module is to first differentiate certain genetic conditions from certain non-genetic conditions. That means you need to differentiate between inheritable and the non-genetic or the non-inheritable disease. Now, when we talk about inheritable disease, we will be learning about the autosomal recessive polycystic kidney disease, the autosomal dominant polycystic kidney disease, and of course a little bit about the juvenile nephronophthisis and the medullary cystic disease complex. Okay, these are the ones which are important. And then when you look at the other conditions, they are your medullary cystic disease, congenital nephrosis, familial hypoplastic glomerulocystic disease, multiple malformation syndromes with renal cysts such as your tuberous sclerosis and the von Hippel-Lindau disease. On the other hand, we have certain non-inheritable, okay, or the non-heritable diseases, that is the cystic diseases. Now these are your multicystic kidneys. They are also called as a multicystic dysplastic kidney, that is your MCDK. Apart from that, you have benign multilocular cyst, simple cyst, medullary sponge kidney. Then you can have sporadic glomerulocystic kidney disease and acquired renal cystic disease, or the calycial diverticulum, which is also called as a pylogenic cyst. So roughly you need to know what are the heritable and what are the non-heritable diseases. Okay, and then based on that, let's look at each of those individual topics. So amongst these, most of the questions are asked from your autosomal recessive and autosomal dominant polycystic kidney disease. But at the same time, also look for those keywords amongst the various other diseases which will help you get the answer right. So the first condition we will talk about in the cystic diseases is your autosomal recessive polycystic kidney disease. This is also called as the infantile polycystic kidney disease. Okay, autosomal recessive polycystic kidney disease is also called as the infantile polycystic kidney disease. Okay, now like I told you, the cysts are more or less from the collecting system, the tubules. So that remains true here also. The origin of the cyst is from the collecting duct. Now these patients, there will be relatively rapid, symmetrical and bilateral enlargement of the kidneys in the infants, secondary to the collecting duct cysts. Now the size of the kidney is increasing because the number of cysts are increasing, not because of the functioning of the kidney. Okay, are you getting the point? So even though the size is massive, it is a huge non-functional kidney. That is what is seen in polycystic kidney disease. Now they can be associated with liver issues, and the most common liver issue that we come across is your congenital hepatic fibrosis. And if you look at the severity, the most severe forms appear early in life. That means if by chance the child survives the phase and then continues to grow, most of the times it means that they are non-severe. Most of the times they are a pretty bad disease where the children do not survive. That is why they say the earlier you find, the more severe it is, and these people don't tend to make it out. Okay. Now, if it is not apparent at birth, sometimes it will become apparent later in childhood. This is that other scenario that I spoke about, that they somehow tend to survive that initial phase and come out. They will still have non-functioning kidneys, but let us see what we can do for it. Okay. This is a milder variant. If it is early in age, it is a severe form. Now, this is an autosomal recessive condition, of course, as the name suggests it. The problem is with this PKHD1 gene, which is on 6p12. Now, this codes for fibrocystin or polyductin. Remember this, polyductin. Okay. This is for autosomal recessive polycystic kidney disease. Okay. There is something called as polycystin. And this is for autosomal dominant polycystic kidney disease. Please don't get confused. Okay. You have polyductin, polycystin. Okay. I know it gets confused because ductin has D in it and we tend to remember it as an autosomal dominant disease. But this is one area where you have to think of it the other way. Okay. So if there is a D, it is not dominant. Instead, it is a recessive condition. That is where you have to be a bit careful, because you tend to get carried away with that word because they sound very similar. Okay. And the other word for polyductin is fibrocystin. Coming to the features, you're going to have enlarged and echogenic kidneys, and this is usually found out in your antenatal scan. Okay. Because it's in utero. Antenatal. Now, I told you it is just a condition where there are a lot of cysts, but not much of a functioning kidney. So, if the kidney doesn't function, there is no urine. So, if there is no urine, there will be oligohydramnios. Okay, so there is no fluid around the baby. So, then what's going to happen? The baby does not have space to grow. So, the uterus kind of contracts around the baby. All right. So, it kind of squishes the baby. That is what's going to happen whenever you have oligohydramnios. Okay. And that is called as the Potter's sequence. Okay. Amongst this Potter sequence, you will have Potter's faces, deformities of the limb. You will have respiratory distress because of pulmonary hypoplasia. Even the lungs are not allowed to expand and grow. So usually these children don't survive. Okay, they don't survive. Now the affected newborn usually has enormous kidney-shaped non-bosselated flank masses that are hard and they do not transilluminate. So normally you would assume that if there are a lot of cysts, they're supposed to be transilluminate, but these cysts are very, very small. Okay, there are tiny cysts, but multiple. Okay, so you will have a large kidney, more number of cysts. Okay, but tiny, tiny cysts. So they do not transilluminate that well. Now, sometimes the kidney is so huge, which causes an increase in the size of the abdomen that it doesn't allow for a natural delivery. Okay, that is how big these kidneys can grow to. Now, eventually, the serum creatinine and the blood urea nitrogen will start to rise up. That is because the kidneys are not functioning and they are not compatible with life. Almost 50%, that means 30 to 50% die shortly after birth. And this cause of death is not the renal failure. Okay, it can be uremia or respiratory failure, but most of the times it is the respiratory failure. This is the most common cause. So the most common cause for death in a case of polycystic kidney disease is pulmonary hypoplasia, leading to pulmonary failure or respiratory distress. 100% of these patients will have an associated liver involvement. Okay, liver, if kidney is involved, liver will also be involved. Keep that in mind. Now, most of these patients don't survive. By chance, if they survive and come out, these patients will eventually have some sort of renal functional impairment. So, the kidneys are not functioning. We have already discussed there will be hypertension, renal insufficiency and liver disease. Why? Because 100% of these patients will have a liver involvement. So, not only is the kidney not functioning, you will also have associated liver problems. In the kidney, you will find renal calcifications. And when it comes to liver, these patients will have portal hypertension, esophageal varices and hepatosplenomegaly. Liver enzymes per se will be normal, okay, and there is no increased association with malignancy, okay, but eventually it's a very, very tough condition to deal with. Now, whenever you do an ultrasound of the abdomen, you will find bilateral, enlarged, diffusely echogenic kidneys. Of course, the echogenicity, I've already told you, it is in comparison with the echogenicity of the liver, okay. You're going to have your salt and pepper pattern. This is what I was talking about. Tiny, tiny cysts, multiple cysts, but tiny cysts. So these tiny cysts will start looking like a salt and pepper appearance. Okay, like this salt and pepper appearance. You will not have your big, big bosselated cysts like this. Okay, not huge cysts. They're tiny cysts. And that is what is seen in autosomal recessive polycystic kidney disease. Remember this is very important. Salt and pepper appearance or salt and pepper pattern is seen in autosomal recessive polycystic kidney disease. So as we discussed, numerous microcysts will be there, and the involvement of the kidney and liver are inversely proportional. That means more is the kidney disease, less is the liver involvement. That doesn't mean liver involvement is there, but the degree of involvement is less. Okay, so more is the renal involvement, less is the liver involvement, and vice versa. If the kidney is not that badly damaged, the liver is damaged. So either way, it's a bit of a tough or a tricky scenario to deal with. Okay, so liver and kidney are inversely affected. Now, if you look at the cure per se, unfortunately, there has been no cure that has been diagnosed for your autosomal recessive polycystic kidney disease. If they survive and come out, I told you they will have some sort of oligohydramnios which causes pulmonary hypoplasia. So you will give them some sort of respiratory care. They will have hypertension because the kidney is not functioning. So you can plan a nephrectomy to control the hypertension. Apart from that, you will have to try and manage the hypertension, the congestive heart failure, the renal and the hepatic failure as well. And if the patient has portal hypertension, consider a splenorenal shunt. That is one of the options available to treat this particular condition. Eventually, the end result will be that these patients will need some sort of dialysis and renal transplantation on the long run. Okay, there is no running away from it. Now, let's look at the other condition, that is the autosomal dominant polycystic kidney disease. This is also called as the adult polycystic kidney disease. Okay, this is more common when compared to the infantile variant of the autosomal recessive variant. Now, if you look at the incidence, it's about 1 in 400 to 1 in 1000 live births. Because it is autosomal dominance, there is a 100% penetrance. That means if a particular patient has it, his son or daughter or child will have this particular gene being transmitted to them. So, autosomal dominant polycystic kidney disease will be there. 10% of these can occur sporadically. Keep this in mind, this becomes important while you're diagnosing a case of polycystic kidney disease. Okay, in 10% of cases, you can have sporadic cases of polycystic kidney disease. Now, looking at the genetics, very, very important. Please pay attention. There is something called PKD1 and PKD2. This has been well described. What is the latest one is your PKD3. This has been hypothesized. Okay, but they've still not found out which gene this PKD3 is there. Okay, this is a very, very mild variant. Okay, mild variant of your autosomal dominant polycystic kidney disease. They're still not found out on which gene it is. It's still in the hypothesis phase. Now, let's look at this PKD1. This is present on the short arm of chromosome 16 and it codes for polycystin 1. Polydactin was for autosomal recessive. Now, this is more common because it affects 85% of the cases, and it is much more aggressive because it rapidly progresses. Okay, it rapidly progresses. So, this is an aggressive variant. Now, if you look at the age of presentation, it's usually at around 20 years they develop the cyst, and by the age of 50 they end up with end stage renal disease or renal failure. On the other hand, if you look at the PKD2, this is present on the long arm of chromosome 4 and it codes for polycystin 2. And like I said, this is a slightly rarer variant, and this is slightly milder also when compared to PKD1. Okay, it affects only about 15% of patients with polycystic kidney disease, and because it is a milder variant, the presentation will be that much more later in life, usually in their 7th to 8th decade, that is the 70s of their age. And even more milder variant is your PKD3, which is still in the hypothesis phase. Now coming to the presentation features, most of the times they present you in the 4th to 5th decade of life. Now if they ask you the most common presenting feature, okay, most common feature, it is hypertension. That means by chance they have gone for a BP check, they have found the patient has very high blood pressure, they evaluate, they find a polycystic kidney disease. So please note, patient has not come to you. By chance, while doing a routine health check or something, you have identified hypertension. So that becomes the most common feature. But the most common complaint the patient comes to you with is pain. Pain. Okay, this is the most common. Okay, this is the most common complaint that they come to you with. Now, why will there be pain? Because the kidneys are enlarging in size. So there is a mass effect. There is a stretching of the capsule that is happening. All right. So you will have stretching of the capsule, mass effect. And sometimes they may bleed into the cyst. Okay, they will be bleeding into the cyst. Now these patients are also prone for urinary tract infection, which can cause pain. They are also prone for developing stones inside the kidney. That is the nephrolithiasis in about 25 to 30% of patients. Again, these also can cause pain. All right. Now going ahead, the other features that these patients can present to you with is presence of microscopic and gross hematuria. They can come to you with gastrointestinal symptoms. And whenever you do an IVP, intravenous pyelogram, and you look at the renal calyx, you will find a spider leg appearance. So basically what happens, let us assume this is your calyces which eventually come and form the renal pelvis, and they're going to come out like this, correct? Now I told you the cysts are in the collecting system. So the cysts are here which kind of enlarge in size and they compress your collecting duct. Okay, they compress the renal pelvis. Now the pelvis will become thin like this. Okay, now the renal pelvis will become very thin. You will see something going out here, something going out like this. So this looks like a spider appearance, okay, like a spider leg appearance. That is what you're going to find whenever you do a intravenous pyelogram, because of the compression and elongation of the renal pelvis and the renal collecting system. Now, this is a very, very important point. This autosomal dominant variant of the polycystic kidney disease can present in conjunction with tuberous sclerosis. Okay, it can be present along with tuberous sclerosis, and that is because of a condition called as a contiguous gene syndrome. What is this contiguous gene syndrome? So I'm sure most of you would have kind of faced this sometime in life. All of you are sitting on a compound or something like that with your friends. Somebody pushes you back. When you're going back, the first thing you do is you're going to grab hold of the person next to you to try and stabilize yourself. Most of the times what happens, you'll also fall, you'll pull down that person along with you as well. That is what happens most of the times. Here, the same thing happens at a genetic level. When there is a mass deletion happening, okay, or a major deletion happening in a particular chromosome of that particular gene, even the gene which is next to it also can get deleted. Okay, that is what is called as a contiguous gene syndrome. That means if one gene gets deleted, the gene next to it also can get affected. That is what we call as a contiguous gene syndrome. Okay, so what happens here is they are characterized by multiple apparently unrelated clinical features. Okay, not because it is because of the kidney disease. It is because of the loss of gene which is next to it as well. All right, that is because of the deletion of the multiple adjacent genes. Now, with regards to the polycystic kidney disease, that is the autosomal dominant variant, that is a PKD1 gene. Okay, this PKD1 gene is adjacent to the TSC2 gene. Now, this TSC2 gene is seen in tuberous sclerosis. Okay, this is seen in tuberous sclerosis, and of course it is present on chromosome 16. That is why it's next to it. So large deletion of this particular gene can also cause deletion of your TSC2 gene. Thereby, the patient will have features of both the autosomal dominant polycystic kidney disease and that of the tuberous sclerosis. So it is not that it is associated with this, but it is because of the contagious gene syndrome. Now, there are certain risk factors where this end-stage renal disease will appear at a much earlier age. Okay, basically there are risk factors for early onset of end-stage renal disease. PKD gene mutation, PKD1 gene mutation, like I've told you, it is a more aggressive and a progressive variant. Male sex, higher risk. First episode of hematuria if it is before the age of 30. If the onset of hypertension is before the age of 35. Hyperlipidemia, sickle cell trait, and remember, size is inversely proportional to function. That means more is the size, less is the function. So which is indirectly telling you that the larger the size, it is a earlier predictor of the patient eventually ending up with end-stage renal disease. Now you can have certain extra-renal manifestations. Most common is your hepatic cysts. Okay, because it's a cystic disease of the kidney, you can have cysts elsewhere in the body as well. That is what we call as an extrarenal manifestation. And the most common of this entire lot is your hepatic cysts. In recessive variant, we found what? We found congenital hepatic fibrosis. Here we are finding hepatic cyst. So there are two separate conditions. Okay. So here this is seen in both PKD1 and non-PKD1 genotypes as well. Other areas where you can find a cyst are in the brain, the intracranial aneurysm such as the perianeurysm. Then apart from that, you can have cysts in the seminal vesicles in about 40%, arachnoid membrane 8%, pancreas 5%. Now if these patients have cysts in the seminal vesicles, sometimes they can cause infertility. Very, very rare, but it can cause infertility, but very rare. If it's the arachnoid membrane and the pancreatic cysts, they are asymptomatic. Okay. Now, because there is kind of dilatation everywhere that's happening, even the heart valves, if they dilate, the valves will prolapse. The valves are no longer in a position, so they can prolapse. So these patients can have mitral valve prolapse and they can have colonic diverticulosis. Why? Again, because of the dilatation, there is weakness and you will have colonic diverticulosis. What about its association with RCC or the renal cell carcinoma? The incidence of renal cell carcinoma in a patient with autosomal dominant polycystic kidney disease versus that of a general population is the same. Okay, it is the same. But the only thing is they appear at a younger age. Most of the times they present you with bilateral RCC when compared to a unilateral RCC. Okay, so here you can see that the incidence is more 12% in polycystic kidney disease versus about 1 to 5% in general population. And if you look at the type of RCC, they are usually multicentric and sarcomatoid type. But overall, the risk of developing cancer is the same as that of general population. Now, coming to the diagnosis point of view, so far I only spoke about genetics, but you need to have a imaging criteria as well, correct? Now, you can have simple renal cysts also, at the same time you can have a polycystic kidney disease as well. Now, you need to know which is classified as simple cyst and which is classified as a polycystic kidney disease. So for that, we have something called as the Revine criteria, and this is done when there is a family history. Okay, you have a family history of polycystic kidney disease, and now the next progeny has come. You're doing a scan for them. Why? Because there is 100% penetrance. So you're doing a scan, you find the cyst. Not all cysts are called as polycystic kidney disease, so there is a criteria for it. That criteria is a Revine criteria. Okay, that is the Revine criteria. So here what they've done, they've divided them into age groups. First is 30 and less than that. Next is 30 to 59 years of age. And the last one is greater than 60 years of age. So they've taken 3 criteria, put them under 3 different age categories. And in the first category, that means if the age is 30 or less, all they need to have is 2 unilateral or bilateral cysts. That means if both kidneys are involved or if there is 2 unilateral cysts. Okay, two unilateral cysts or bilateral. That means either both kidneys or two cysts in the same kidney. So overall, all you need to have is a minimum of two cysts. Okay. Then, if the age is less than 30, diagnose them as polycystic kidney disease. If it is 30 to 59 years of age, the number of cysts need to be more. Here, two cysts in each kidney. That means you need to have four cysts. Two this side, two that side. In the presence of family history, then Rabin criteria is kind of accepted. Diagnose them as polycystic kidney disease. If the age is more than 60 years of age, okay, now you need to have four cysts in each kidney. That means 8 cysts overall. 4 in the right, 4 in the left. Then you're going to diagnose them as a polycystic kidney disease. And this is your Rabin criteria. What about the Grantham criteria? This Grantham criteria is used when there is no family history. If there is a family history, you will use Rabin. If there is no family history, this is for the 10% of population who can develop a sporadic adult polycystic kidney disease. Okay, 10% of population can have a sporadic disease. So for such patients, you will apply the Grantham criteria. Here what you're looking for is bilateral renal cysts that are present, and along with that you should have 2 or more of the following symptoms: bilateral renal enlargement, 3 or more hepatic cysts, presence of extra renal manifestations such as the cerebral artery aneurysm, or a solitary cyst of the arachnoid, pineal gland, pancreas or spleen. So if you have renal cysts and 2 or more of the following symptoms, you will diagnose them as the adult polycystic kidney disease or the autosomal dominant variant of the polycystic kidney disease. So how are you going to treat these patients? As of now, the current therapy is directed towards lessening the complications of the adult polycystic kidney disease. Basically, we know that these patients will end up with renal failure. Your idea is to try and delay that onset. So as of now, there is no known cure, just like recessive variant. Try and treat the hypertension. You will use ACE inhibitors, okay, or you can use angiotensin receptor blockers. Try and manage the analgesias, give them good pain relief. Cyst aspiration, deroofing or nephrectomy can be considered if it becomes too big and it is causing a mass effect and causing trouble elsewhere. Whenever we talk about Berry's aneurysm, we take 7 mm as the cutoff. So when you're screening, if you find a Berry's aneurysm and it is less than 7 millimeters, just observe. But if it is more than 7 millimeters, you will have to intervene. Intervene in the form of doing some sort of clipping. Okay, that is what we are going to do whenever we come across a Berry's aneurysm. Last 2 conditions in the blanket of this polycystic kidney disease is the presence of juvenile nephronophthisis and medullary cystic disease complex. Okay, now both these conditions, they are a group of genetic ciliopathies. They can have similar histopathological appearance of the kidneys. Here you will have interstitial fibrosis. Now the way of differentiating between the two is to look at the mode of inheritance, the age of onset and the presence or absence of extrarenal organ involvement. First, let's talk about juvenile nephronophthisis. Here, this is an autosomal recessive variant. Okay, autosomal recessive variant. 10 to 20% of patients will have renal failure occurring in children. The most common symptoms that they come to you with is polydipsia, polyuria. Renal tubular urinary concentrating defect will be there, so they tend to lose a lot of salt. So they will have salt wasting syndrome. Please note there is no hypertension. This is important. This is the clue for identifying juvenile nephronophthisis. There is no hypertension. And extrarenal manifestations are present. On the other hand, hypertension will be there and extrarenal manifestations will not be there in the other condition. And end-stage renal disease, the age of onset is much early, that is at 13 years. So if you look at the other variant, that is the medullary cystic kidney disease. Okay, Here it is autosomal dominant. There it was recessive. Here they will have significant hypertension. In juvenile nephronophthisis, no hypertension. End stage renal disease, later onset. There it was 13 years. Here it is 30 years, 30. And here there is no extrarenal manifestations. There was extrarenal manifestations. So now let's look at those extrarenal manifestations. What all can they present you with? They can present you with retinitis pigmentosa, that is also called as the renal retinal or the senior Loken syndrome. They can present you with skeletal abnormalities, hepatic fibrosis, Bardet-Biedl syndrome, which is basically a combination of obesity, intellectual disability, polydactyly, retinitis pigmentosa and hypogenitalism. They can present to you with ocular motor apraxia, that's called as a Cogan syndrome, or they can present with Joubert syndrome. So these are all the extrarenal manifestations, and extrarenal manifestations are seen in juvenile nephronophthisis. Okay. If you look at the histology based on the gross and this one, here you're going to have small kidney. In polycystic kidney disease, large kidney. Here there is a small kidney. There the cysts were in the collecting duct. Here the cysts are in the kidney, the parenchyma. Okay. So the cyst is at the corticomedullary junction. Okay. That means the cysts are in the parenchyma. In the polycystic kidney disease variant, it was in the collecting duct or the tubules. Now, in the tubule part, you will have irregular thickening and disintegration of the tubular basement membrane. There will be marked tubular atrophy with a cyst development, and there will be interstitial fibrosis because of cell infiltration that happens. When you do an ultrasonography, most of the times, because the cysts are very small, you tend to miss them on an ultrasound. Okay? Because the parenchyma appears hyperechoic secondary to fibrosis, the tubular interstitial fibrosis. So in such a setting, it becomes very difficult to identify the cyst. So the most sensitive investigation to identify the cyst is your contrast enhanced CT or your contrast MRI scans, which will help you pick up these corticomedullary endomedullary cysts. That means cysts in the parenchyma. That can be picked up with the help of a CT or an MRI. Management of these patients is supportive. Provide volume contraction. They're losing a lot of salt. Renal azotemia. Sodium replacement, sodium restriction or the use of diuretics should be avoided. Why? Because they're already losing salt. Okay. So later, eventually the patient will end up with some sort of renal replacement in the form of dialysis or transplantation. And allografts apparently are not susceptible for developing the disease. So you can give them allografts as well. So this was regarding your juvenile nephronophthisis and your medullary cystic kidney disease. Now, a quick glance at the difference between the two. Juvenile nephronophthisis is more common. Medullary cystic kidney disease least common. Autosomal recessive, here it is dominant. 13 years, 30 years. No hypertension, with hypertension. Extrarenal manifestations are present. Here they are absent. Okay. So remember this table. This will help you differentiate between juvenile nephronophthisis and your medullary cystic kidney disease.